Hello, everyone. I will present our early experience with Pipeline Vantage. And as you know, Pipeline represents an important part of the recent history on the endovascular treatment. If you see the timeline, you will appreciate several different milestones. Most of them are clinical trials focused in safety and efficacy. And also you will see the launch of the different generation of pipeline. Since 2008, they received the CE approval and they launched the pipeline, then the Pipeline Flex. They changed a little bit the delivery system. The third was the Pipeline Flex Shield, in which they work on the surface in order to get a less thrombogenic material. And the last step is the Pipeline Vantage. This is how it looks like. They kept out the Shield technology, but other than that, they changed completely the device. They work in order to get a better distal access to the distal anatomy. They have two platforms, O27 and O21. Also, they optimize the brain size in order to improve the overall performance, and they also focus and promote the utilization. They base this strategy in four different levels: the optimization of the ball density, the wall thickness, also to enhance the wall position, and of course, the Shield technology. The main difference between Pipeline Flex and Vantage is while the Pipeline Flex is made with monofilaments of cobalt, chromium, and platinum, the Pipeline Vantage is made with a technology that each wire it's made with a draw field tubing, which means that the outer sheet is made with cobalt chromium to provide the strength, and the platinum core provide the radio opacity to the device. In the O27, in the big platform, you will find 48 wires with this technology, and the remaining 16 are made with cobalt chromium. And in the platform of O21, all the 48 wires will be made with this technology. Regarding the pusher, it's different. In Pipeline Flex, you have a hollow hypotube with O20 wide. They change in the new model. They have a continuous core wire with an integrated, the bumper is completely integrated. And in the platform O27, the pusher is O23 wide, and in case of the O21, it's O18. All provides to the system. The idea is that they have a better overall stability and one-to-one response. Regarding the distal end, also they changed a little bit. They repositioned the sleeves, and also they get a thinner sleeve, 44% less of the thing. It's thinner. Regarding the wires, the large diameter of 64 wires pipelines, they increase the relative pore density because you have more wires, and also they reduce the wall thickness because each wire, the profile is thinner and give a thinner mesh. Thereby, they maintain the metal surface coverage if you compare with the predicate, which is the Pipeline Flex. Assuming that most of you know the behavior of Pipeline Flex, we will use like the predicate in order to establish the comparison. In my understanding, the behavior of the new device is better, have a better navigability, have a faster distal anchoring, and also a better wall position. And of course, in my opinion, the visualization is pretty good because it's more homogeneous. Then I will show some slides. This is our experience. Just 20 patients, 18 aneurysm, and one patient we treated two at the same time, and 3 patients with dissection. And also, we performed 10 cases in model, and this was our first case with the O21. The visualization, I think it's pretty good. here. Regarding the navigability, I think if you compare with the predicate, the navigability is pretty good. There are less friction, and good sign on that, or in line with that, is you can see the distal tip of the micro is completely still, not movement, despite the lot of bends and curves that you have to face during the approaching. The device is completely still. Also, the faster distal anchoring is something that strikes me a little bit, because in comparison with the Pipeline Shield, it's faster and very easy to get this distal opening. Sorry. Regarding the deployment device, I think the behavior of the device, it's of course have radial force, the spring force. It's like any device made with cobalt chrome, but however, it's present an adaptability during the deployment similar to the nitinol. It's a stent made with cobalt chrome, but remember a little bit when you deploy the stent and the nitinol devices, the wall opposition. Also, I think it's better if you compare with the Shield, and the homogeneous radio opacity which provide the technology. I think it's good because it's easier to understand what happened with the stent when you see the wall opposition, or when you are trying to evaluate the position of the stent. I will show you with some cases. This was our first case. It's a carotid ophthalmic aneurysm. We performed the treatment with Vantage. We took probably 1 minute to deploy the device. But because I made an error, a mistake, the size of the proximal size of the stent, it was not enough. We decided to treat with a second one, but I didn't have the Vantage, the correct size, and I used a shield, a 5 millimeters shield. And it was, finally we have to start almost at the same position that we started with the Vantage, and it was completely different, the maneuver. We took more than 15 minutes with this treatment, and despite different maneuvers, it was impossible to open the device. And you can see here, this is why finally, the final picture when I finished the deployment. And here you can see the Vantage, and here is the Pipeline Shield. With ballooning, we used balloon remodeling in order to improve the wall position of the stent, but it was so difficult. Finally, we have to tolerate the gap in between the stent. And you can see this picture of Vaso CT. You can see in the Pipeline Vantage and also the Shield, you can see the difference between the stent in the Combin CT or Vaso CT. And here you can see in axial view, you can see the better wall position of the Vantage, and here is the Pipeline Shield. This was our second case. The patient arrived with a fusiform aneurysm with ischemic symptoms. We decided not to treat with devices. We put a double antiplatelet therapy, but the patient in the next week or 10 days, the aneurysm grew up a lot, and we decided to treat. This is our first case with the platform of 021. It was very user-friendly device, no issue. And this was the picture. Finally, we have to put two in lines because we decided to put the stent in the internal carotid artery. And this was the final picture. And this is the 1 month follow-up in the CTA. Okay, this is it's an acute case. It's a cave aneurysm. And it was our first acute case. An easy treatment, no issue. This is a cavernous aneurysm. You can see the navigation and the visualization of the stent. I think it's quite good. And this is the stagnation inside the aneurysm, and this is the follow-up of 3 months. This is a case, it's a recanalized aneurysm. We decided to treat using the radial approach with wrist and Phenom Plus. We like this tandem. Here you can see the approach. Yeah, and this is, we decided to go distally with Phenom Plus in order to give support to the whole system. No issue, it's in relative easy case and the final run. Regarding the wrist, you know, it's a guiding catheter designed or dedicated to use by radial access, and the transition and the number of the transition, I think in the right position to get the best performance possible to the catheter. This is a carotid ophthalmic aneurysm also. This is the first run. You can see we made a little mess inside the aneurysm in order to reach to the distal position. We use a echelon 10. In order to rectify all the catheter, we use a low-profile stent retriever. This is the maneuver during we move distal to the aneurysm, the Phenom Plus, and this is the opening. We use also the Phenom Plus in order to open and to have a better control of the maneuver. And this was, we put some coils because the size of the aneurysm, and also presented an enhancement wall in the MRI. And this was the final run. And this is the last case, an acute case with a long dissection, the symptomatic patient in niche of 16. The patient arrived to the hospital. We have to recognize the artery, and we used Pipeline Vantage 6x50. We open with ballooning, and this was the final run, you can see. In conclusion, in my understanding, the new Vantage, the 64 wires, the behavior is better, quite better, have a better wall position, better distal opening, and something that I felt was when I start to deploy the stent, I felt the tension, the basal tension of the deployment was lower, probably 1 or 2 steps below compared when you work with Pipeline. The visualization is quite good, and the deployment maneuver, it's really relative different compared that you have to use in Pipeline Shield. And regarding the O21 platform, I think it's an extremely user-friendly device, have a better anchoring comparing with nitinol devices, great navigability, and also a good visualization. Thank you.
You know, it's your symposium, so I don't know. So there is a second speaker in the symposium?
Yes, Dr. SIDDIQUI.
Dr. SIDDIQUI? I mean, he's not there. Okay, so you have a recorded video conference. Okay, so good. So,
hello. The task today I have is to share with you some early experience with the brand new family addition to the Solitaire, the 3mm device. These are my disclosures. So the Solitaire X 3mm device is the newest member of the long line of very successful stent retrievers we have that really have been foundational in the change of stroke intervention from medical to interventional. And it's the newest member of this long line of family of stent retrievers, including its most recent sort of brethren in the 6x40 and 4x40 longer lengths. We now have a member of the family, which is designed for more distal locations. It's a smaller device, which is the 3x20, and it serves this role very well. So what is the same? Well, it's still the parametric design, so it still overlaps. It's not circular. It is a sheet that overlaps, and it still has the platinum markers for additional visualization along the length of the device. The push wire is the same, and you can deliver it through a 21 microcatheter without a problem, or anything larger, and it's compatible with all standard aspiration catheters as well. As far as indications for use are concerned, it is approved for treatment in vessels as small as 1.5 millimeters. What is also unique is that it can also be delivered through an 017 microcatheter. So this really is the first time we are be able to use a standard Solitaire through a 17 millimeter 017 microcatheter. And you can use the Trevo Pro 14 or the Headway 17 or the VS 17. These are the microcatheters that have been tested and approved. There might be others that are 17 that have not been tested. The pusher wire is a little different. It's an 0155 pusher wire, which really allows it for compatibility through these smaller microcatheters. And then it also has a fluorosave marker like everything else. And then the device itself, it really allows for usage in vessels from 1.5 to 3 millimeters, and the standard length is 20 millimeters, which is appropriate. Anything longer than that really becomes problematic in these distal vessels, which tend to be much more tortuous. And so you can see you can use these in all different kinds of vessels with all different kinds of microcatheters, and it really allows you to get the clot out without too much excessive motion. And the way you can really appreciate this is that the radial force is really lost when you start getting to beyond 2 to 2.5. So this is really designed to be optimal in those smallest of vessels, which are 1.5 to 2 millimeters. Anything larger than that can be used, but it ends up being too parametric or too overlap. So this is sort of to give you an idea as to how that works, is that in a 1 millimeter vessel, you'll have about 65% overlap. In a 2 millimeter, about 36%. In a 3 millimeter, about 27% overlap. And so the working length really is also reflective of that, is that the larger the vessel, the smaller the working lengths. And this is something to really keep in mind, that this allows for dynamic clot integration using the parametric design, because the flexibility of the parametric design allows for better clot integration. So how best to illustrate whether there is value in this methodology for distal vessels? One of our biggest concerns with distal vessels are that they are much more flexible, and therefore the distortion caused by a stent retriever can be significant enough to cause a high risk of hemorrhagic complications, particularly with small perforators getting pulled out as one retrieves fully deployed stent retriever from more distal to more proximal locations, compared to more proximal locations where the vessels tend to be a lot more sturdy and tethered. Distal vessels tend to be much more flimsy and therefore at higher risk. And so this is best exemplified through this video as demonstrated in this little chart here. And I'll turn the music off for reduced dramatic effect. And what you see is this is the same piece of plastic tubing, and this is the Trevo versus Solitaire. And as the Solitaire is being pulled, it is deforming the plastic tubing a lot less than the Trevo is, which is an innate property of the mechanical features of the device. So this in vitro test would suggest that the deformation of vessels inside the body during retrieval is a lot less with the Solitaire, likely related to its parametric design and reduced radial force compared to the Trevo, which is the traditional cylindrical device. And I think that can significantly improve the possibilities of not causing adverse events, even if they're typically asymptomatic, such as the subarachnoid or intracerebral hemorrhages noted after centrifugal, particularly in distal locations, which remains a primary concern of this approach. So here's some of my initial experiences with this. This is the first case. It's a patient who has come in with NIH of 14, left hemiparesis, and has multiple clearly embolic infarcts, ACA and MCA, receives TPA. Here's a perfusion study. You can see there's a distal MCA and a whole ACA infarction ongoing right now with preserved volume as demonstrated here, and flow is down. So high risk area, you do an angiogram, and then you can see our 88 guide is there, and you can see a distal ACA lesion, and on the lateral view, you can see the distal MCA lesion of the inferior trunk as well. So we have a Sophia intermediate catheter, a Phenom 21, Solitaire 320, and this is the video of the case, which I'll narrate for you. There you can see, we see the ACA, and the patients are awake, so we're showing the unsubtracted images just for better visualization. There you're seeing us get into the ACA with a Phenom 21, cross the lesion, and you can see the lesion sort of starts clearing up. The contrast that was built up has cleared up. Now simply we confirm with a microcatheter injection, we are intravascular, there's no issue, and then we bring up our Solitaire. This is a sped up movie, so things are a little faster than they would be in real time. And so there the stent retriever is deployed. And when we have this in place, then we actually bring our aspiration and guide catheters up over this, retrieve it, and we have complete revasc of that lesion. And now we are left with this inferior trunk. So we go back up again. I prefer starting off with these U's, which really help us get into the right location. There's the intermediate catheter brought up, and now we are getting into the right branch. The microcatheter is used. The clot is a little tough to cross, but the fact that we have a J really gives us confidence that we are going to be okay. And then we just pull, push till we get to the other side. And once we have it, then we do a microcatheter run, again confirm we are distal, and now again deploy our stent retriever with our aspiration catheter just proximal. You can see this was the wedge that we were concerned about, and it's being deployed there. And after it's deployed, we do a run, and you can see there's almost complete flow arrest. There's probably a goober sitting in there. We start deploying it and then retrieving together, corking the clot as best as we possibly can, and then do another run after this. And so now we have this one branch that was closed, is open. There's still some delayed filling. There's a small wedge. This remains. This is the last one, the last image. There you can see this is open, but there's a small area here right at the watershed with the PCA. We call it a day here, and our NIH post-op is 2. So we went from 14 to 2, and next day MRI shows a very small infarction in distal ACA in a small area in the paracentral region. The patient does exceptionally well. So this is 2 distal locations in the same patient treated with the same device with great effect. Here's more of a traditional situation when we are using these cases. It's a patient who's found NIH of 9 with the left M1 occlusion, outside TPA. You can see the volume is starting to go down, flow is already pretty far down. There's the M1 occlusion on 4D. And so again, we use an 88 system, and this is a video demonstrating how we are able to use this. So again, this is classic M1 occlusion with poor collaterals coming in from the ACA. And there we're crossing the lesion with the J wire. There's the aspiration catheter system. To confirm, run, make sure that we are distal. There you can see the bifurcation. Here we use a 640 device as a first device that is being deployed now, and then use aspiration and stent retrieval collectively to pull this. This is with the Solitaire in place, and now we are retrieving the two together, corking this, and then pulling the whole thing together as one unit. Now, this is immediately afterwards. We say, okay, we are good, but there's a superior trunk occlusion and M2-3 junction occlusion. So this is where we now bring in our friend, the 3x20 device, and we go into the superior trunk, which seems to be occluded. There we are going beyond, confirming with a run that we are in the superior trunk. There we are, and we're distal to the lesion. And so now we go ahead and deploy a 3x20. And once we have deployed it, we then give it usual time, retrieve it. And as we retrieve the device, you can see patients always feel it. There's the aspiration catheter. This is the final run after completion. There's a small area here with reasonable collaterals, but given the tortuosity that was there and the distal location, we stopped there. The patient improves from NIH of 9 to 6 immediately post-op, and as expected, left frontal region, they have issues with language, which complicates the exam. However, importantly, this is their CAT scan a week out. Their pacemakers or MRI could not be done, but this shows no infarction in that small area that we are concerned about, and I expect this patient will make an excellent long-term recovery. So these are just a few cases to demonstrate the value of being able to get a small device out for stent retrieval. I certainly use aspiration very frequently, but I do believe that stroke requires a toolkit, and having a small stent retriever that one can deliver safely through smaller microcatheters in distal vessels is an invaluable tool in the armamentarium of a stroke interventionalist. Thank you.
The program is a little bit upside down, so we are going to replace and reposition things. So there is nobody to manage the end of the symposium. So I'm going to ask the people in the room if there is any comment on the first presentation of this symposium about the Vantage with better visibility due to the PFT wires. Do you have any comment on that? People, do you have experience with this new Vantage? Nobody has experience with the new Vantage. I'm sure there is somebody experience with the new Vantage. Yeah. Christophe, you have experience about it? Not at all. Not at all? Okay. Okay, Sal. Take a microphone.
Yes.
No, this is a laser pointer. But it's okay, you know.
Sorry, yeah, it's definitely more visible. It opens much better than the old version with Pipeline. So these are the two comments I'd make about it. We've only done 7 cases so far, so it's still early experience.
Okay. Other question on the Vantage? Okay. Question on the Shield, because the Vantage is also a Shield technology. Did you move to single antiplatelets treatment? Yes or no? Not yet? Not yet? Not yet. Okay. Regarding the presentation that was done by Dr. SIDDIQUI, of course, usefulness of getting the smaller stent river. There is no question that if you look at the evolution of the stent river and also aspiration, we go more and more in distal vessel and small vessels. So having a smaller stent river for tiny vessel is definitely something that is useful. To my understanding, the big concern is, the smaller you go, the more exposure to some potential complication, definitely. So this is something that has to be evaluated on the long term. A comment on this? No comment? Says, comment, Tudor. Well, you can come here because, you will be sitting as a faculty, so you can take a seat.
Yes, I know. Thank you. So I agree. There's a higher propensity for complications. But on the other hand, we also can manage these complications easier, because if you perforate an M3, you can plug up the vessel. It's not as catastrophic as perforating a carotid terminus. So it's not only we have to keep in mind the potential for complication, but also the consequences of these complications, which I think are probably less ominous than in more proximal vessels.
Okay, thank you. Yes?
No, I just want to add that to answer this question, there are a couple of trials that are starting in the next weeks or months, and I think they are hardly needed, because we have all experienced bad and good cases, and yeah, just to add that we'll have solid evidence coming up.
The beauty with the stroke, and this is something that we irritated from the neurologist, and especially from Tudor. It's an infinity of potential trial. So, for the next 10 years, we will get at least 2 or 3 new trials per year. So it's a lot of paperwork, and it's good for the curriculum vitae, for the people looking for a university position, thanks to the stroke. Thanks to you too.
That's why we do it, Jacques.
Yeah, I know. Okay, so I think we can now close the symposium. It is right on time.